both my husband, Pat, and my son, Cal, experienced diagnostic errors. Cal suffered brain damage from his newborn jaundice when it was misdiagnosed. Today he has significant cerebral palsy. And Pat, my husband, died when he was 45 from a cancer that was appropriately diagnosed, but the pathology failed to get communicated to the doctor or Pat. It was hard for us to understand and believe that this could happen in a developed country like the United States.
You look at many of the statistics as the third leading cause of death in the U.S. Most people are completely unaware of that.
That is the equivalent of 7 or 8 airliners crashing every day with no survivors.
We're probably filling one Arlington cemetery every year from preventable medical harm.
Most of us in medicine just said, well, that's the way it is.
This is a problem that's, hiding in plain sight.
It's urgent. It's a public health emergency.
If you believe first do no harm, there is no excuse for not investing in things which will prevent harm.
We have to acknowledge that to err is human, and then to figure out what do we do with that fact in terms of building a system that's safe for patients.
We got to change it. We got to make it better. And I think many people are working very hard to make it better.
One of the ways to really make a difference is you've got to get patients engaged.
We could prevent many, many, many of these deaths immediately if we just put in the effort.
We need to think about them not as unavoidable, but as unthinkable.
To change patient safety, you have to change everything.
We built it completely wrong. This is a time for openness and honesty. It's not any longer a question of possibility, it's a question of will.
These are not just things that happen to other people. They happen to us, they happen to our families, and they are things that we need to work on.
I cannot change what happened to Cal and Pat. However, my family's story is also a story of awakening, of passion, of change, and hope for the future. Good morning. Again, my name is Sue Sheridan. I'm the Director of Patient Engagement at the Society to Improve Diagnosis in Medicine, known as SIDM. You just heard and you just saw the beginnings of a documentary called To Err is Human that featured my family. And it also highlighted the alarming challenges that we're all facing about patient safety, not only in the United States, but in your countries as well. It also gave a message of hope and a pathway forward. We've got to change everything. We've got to get patients engaged. And when I say patients, I mean patients, their carers, and their community members. And this really is a question of will. It's about what's in us. This May, the World Health Assembly recognized that patient safety is one of the top global health priorities. Also this year, in research that was supported by SIDM, it was identified that about 1/3 of all serious harms in patient safety events are due to missed and delayed diagnosis, like you heard about Cal and Pat on the video. This is unacceptable. Are we connecting the dots between patient outcomes and medical education? Are we teaching the skills and the competencies to first do no harm? Are we leveraging the assets and the resources and the people at our fingertips to help develop and deliver meaningful, patient-centered, real-world medical education? So when I say patient-centeredness, I think we're all familiar with this gold standard now in delivery of care, patient-centeredness. But how do medical students and professionals learn how to engage us and empower us to be part of the healthcare team and giving us important information to do joint decision making? How do they learn how to deliver care around our preferences, our values, and the outcomes that matter most to us? How do they learn how to do the most effective, efficient, and thorough patient examination, physical and history? How do they learn how to listen to us and communicate with patients? And how do they learn that to err is human, to disclose and apologize when things go wrong? The bigger question is, who would embody the richest, deepest knowledge to help medical learners develop the skills required in patient-centered care? There is no better resource than the wisdom and the lived experience of the patient community itself, the very beneficiaries of our medical education reform. But we have got to change everything.
Schrandt, and I am a patient advocate, as you heard, and I also serve as a senior advisor to SIDM. And I have the pleasure of sharing some good news this morning, and that's that change in healthcare is happening. In research, patients are involved as partners, as advisors, as consultants, even as principal investigators themselves. Patients are helping prioritize research questions, devise clinical trial studies that are more feasible and more patient-centered. They're helping disseminate research results in ways that are actually usable and understandable to patients. And this is happening globally in very structured and systematic ways. In the US, you see PCORI, the Patient-Centered Outcomes Research Institute on the slide. PCORI actually requires patient engagement as a condition of funding research. So in other words, there can be no research without patient engagement. But we're seeing this same change in policy and care delivery. Here, patients have become part of the very infrastructure. They're serving on health technology assessment, or HTA, bodies. They're providing that lived experience in legislative decisions and policy discussions. In Canada, patients are actually part of the accreditation process in hospitals. They help to disseminate accreditation surveys. And then even at the individual hospital and clinic level, patients are part of the process, part of the core. The hospital administrators, senior leaders have recognized the value of things like patient and family advisory councils, or PFACs, and patient navigators. In the US, about 60% of hospitals have a PFAC, a Patient and Family Advisory Council. And actually, the US government looks at having one of those PFACs as a metric in high-performing hospitals. So we see this pervasive, profound patient engagement in all of these facets of healthcare, and it made us curious. We thought, well, what brought about all of that amazing change? So we did some research and identified what we think are some really key components that led to this revolution in patient engagement. Certainly bold, maybe even audacious leadership. A culture that really looks at patients not as passive recipients of care, or to use Gerard's term, horizontal passive recipients of care, but people who can be empowered and activated as partners. Infrastructure that really invites this to happen and supports this work. Time and space for learning and skill building and training. And certainly evaluation, which I would say also includes process improvement, constant learning. So what about medical education? Is this change happening in medical education? Well, in some parts of the world, In some institutions, yes, amazing things are happening in clinical training. Patients are using that lived experience to provide context to illness and disease. They are helping clinicians learn how to gather information from patients so that data isn't missed and mistakes aren't made. But it is not happening in a structured way. It's incredibly fragmented. It essentially depends on luck. It's very much here and there.
So Susan and I are going to share 2 case studies of patients as educators, really to illustrate that patients as educators are more than patients just telling sad stories. Patients are skilled and competent. We can identify gaps and holes in medical education curricula. We can help craft meaningful learning objectives, and we can help make a difference. So going back to Cal, who you met on the video, Cal was born a normal, healthy newborn, and because of a series of cascading failures in knowledge, failures in communication, failures in systems and processes, he suffered preventable brain damage when he was 5 days old. Today, Cal is 24. He is speech impaired, hearing impaired, motor impaired, but he's funny, he's smart, he's actually a stand-up comedian now, and an award-winning playwright. Cal requires that I use this picture because he thinks he looks like a badass, so I agree to always use it. But he has lifetime challenges that he never should have had. So what if I had been invited to be part of the healthcare team and that my reports of serious symptoms of lethargy and poor breastfeeding had been taken seriously and not dismissed as symptoms of an over-anxious first-time mom? What if the young nurses and the residents had been trained appropriately to know the risk factors and identify the symptoms of the onset of brain damage from jaundice known as kernicterus? What if the resident, the pediatrician, the nurse, the neonatologist, the neurologist, the radiologist, and the lab technician had communicated in a coordinated and connected way? I believe Cal's outcomes would have been different. But I couldn't change what happened to Cal. But I found other mothers who had children just like Cal. There was a phenomenon in the 1990s when they were reducing the newborn screening of jaundice, and a population of children with kernicterus emerged. And the mothers found each other, and we started a small organization to partner with the very system who failed our babies. So we partnered with clinicians and researchers, and this is going into the solution. The problem was babies were being harmed. The solution was patients, or in this case, moms, as educators. So we partnered with clinicians and researchers, and we did a series of CME courses that we developed and delivered together. We did grand rounds with residents at healthcare institutions. We partnered with the Centers for Disease Control. They declared this a public health initiative, and they put out publications to their public health officers and educational materials to the public, to parents, and to clinicians. We partnered with accreditors, the Joint Commission, and they educated the 5,000 accredited hospitals in the United States about the dangers of jaundice as well as the solutions to prevent kernicterus. We partnered with nursing and other clinician curriculum developers, and we spread the news around the world. So this power of partnership of patients, public, mothers, caregivers, and the drivers of our healthcare system, educators, accreditor, policymakers, and researchers, we changed the standard of care. And I would say without the mom educators, I would say no change would have taken place.
So as you've just heard, when patients and parents serve as educators, they can provide content in ways that are palpable, tangible, and lectures and textbooks just can't do that. What we now know is we can actually measure the impact, and we are measuring the impact of the role of patients as educators. If you're familiar with rheumatoid arthritis, then you know it can be a very damaging, very devastating disease. And I happen to know that very well. Next summer, I will not celebrate my 30th year with this disease. You see here 3 hands that really help embody what the outcomes can look like in RA. That third hand is the very worst possible outcome. And on the other end is the very best possible outcome. And the difference between those two is as simple as a fast, accurate diagnosis. Because with the effective therapy we have today, there is no reason anyone should end up with the third hand. To drive this point home, people with RA have gotten involved in a continuing medical ed class called RAPID. The curriculum is co-created, co-delivered by people with RA. I'm one of those people. You might recognize my famous hand. It was the second hand on the last slide. And what we are able to communicate as real patients with this disease is the vivid role that general practitioners, primary clinicians play in essentially deciding our fate. So I usually share that I was one of the lucky ones. I was diagnosed almost immediately, and this was even before we had good therapy, but at least I was diagnosed and I got started on some type of therapy. And when you compare me to my colleagues and my friends who have my same disease, even the same subtype of disease, who lingered for years without a diagnosis, without therapy, their bodies are destroyed, absolutely riddled with damage. And if you put us side by side, it doesn't even look like the same condition. And the only difference was getting a diagnosis. We've also been able to measure from this course, is change happening in the learners? And we're very excited that among learners, the rate of diagnosis and referral is 11% higher than in similar clinicians who've not taken the course. We're excited to watch that continue to grow. There's also a rate of diagnosis of at least one case of RA in 47% of the learners. And we've also been able to measure the impact of having patients as educators. And what the learners have said is it really does bring the content to life. It makes it stick. It makes me remember it. I had a clinician tell me last year that said, I've been practicing medicine for 20 years. I have never understood fatigue from chronic disease until I took this course and talked to real patients. And you don't hear people say, I will never forget that pie chart, or I will never forget that spreadsheet with the pivot tables. But you do hear them say, I will never forget that image or that person or that story. So we've got evidence. It's coming in. There's not a whole bunch, but it is growing. And maybe we don't have agreed upon methods or outcome measures for how patients as educators should be employed and used. But what we can agree on unequivocally is that the quality of clinical training cannot and must not be left to chance. There is not a good or a fair reason someone should end up with that third hand on that slide. And the World Health Organization has actually decreed that people have a right and maybe even a duty to become involved individually or collectively in the planning and the implementation of their health care. So if we all agree, then our job is done. Why isn't it happening? Well, we wonder if it's because of these same key elements we talked about earlier. Do we need our champions? Is it about money and infrastructure to make this happen? Is it the residual paternalism in medicine that we really sometimes think about patients as sort of vulnerable beings to be protected instead of people to be educated and empowered and really thrust into the center of their care? Is it the misconception that, patients, I don't want to deal with crying, and are they going to be angry? I don't want to have to deal with that. Is it just a lack of know-how, a lack of training and experience, or is it a lack of evidence? Well, I mean, maybe, but these are the same barriers that healthcare system leaders and governments and researchers and research institutions and academics all faced. And they decided to just sort of plow ahead. They looked at patient engagement really as a moral imperative, and they said, we're going to do it even as the evidence is still coming in. And so they've been able to try to transform the healthcare system and improve patient outcomes as the evidence was being built.
So what can we do now? Let's start with people. When you go back to your offices, and I have to say, it is an absolute privilege for Suzanne and me to be on the stage to share with you this message of patients as educators. But what matters most is what happens when we leave this conference. When you go back to your institutions, when you go back to your classrooms, when you go back to your organizations, when you go back to your offices. That's what really is going to matter. So what can we do now? Like I said, let's start with people. You can go back to your organizations and institutions and identify your champion for patients as educators. Connect with local, regional, and international patient organizations. They are everywhere. Use Google. You know, there's the International Alliance of Patient Organizations, a very well-established patient organization. The WHO has Patients for Patient Safety, a network of around 400 patients. Many have been trained and many are engaged in patients as educators. Research the disease groups in your locality, in your nation. Go where the patients are. Organize a patient and family advisory council at your organization or your medical school. This is a phenomenon that's just beginning to happen in the United States. Integrate patients as educators into your interprofessional education curricula. And at this point, I have to give a shout out to Dr. Mortensen, if you're here, from Boise, Idaho, who invited me to join him and other staff in their interprofessional education curricula. I'll be delivering a class on September 11th, so this is the beginning, and thank you. Also, prioritize. Don't try to do everything. Prioritize a health issue such as patient safety, such as chronic illness, such as diagnostic error. Start with something and then grow from there. And finally, collect and share best practices with each other. You are the community that's going to make a difference. So in conclusion, this is a question of will. Again, it's about what's in us. So going back to the documentary, and you saw briefly my late husband, Pat, who when he was told he had 10 days to live with his cancer, he looked at me and he said, "Sue, I want to go to Disney World and watch my kids, who were then 4, my daughter was 4 and Cal was 6. He said, I want to go to Disney World and watch my kids have the time of their lives. At this time, Pat was paralyzed from his neck down. But we worked with Disney and United Airlines, and within 4 days, 53 of us flew to Disney World to grant Pat his wish. And Pat did die at Disney World on the 3rd day. But during that time, you can imagine the conversations that Pat and I had. They were absolutely precious about our children and what I was going to do as a single mom. The one thing that Pat asked me, he used to call me Brown. My maiden name was Brown, and even when we were married, he called me Brown. And he looked at me and he said, Brown, he said, whatever you do not give up on patient safety. So AMEE, deans, curriculum developers, teachers, evaluators, funders, policymakers, and medical students, do not give up on patient safety. Be the courageous leaders that we need in medical education today. Embrace the wisdom and the lived experience of the patient community as a valuable asset in enhancing your curricula, because without it, your medical education is incomplete. Have the courage and the will to be accountable for patient outcomes so that babies and daddies and other patients can be safe from harm from medical learners taught at your institutions. So remember, we need to change everything. We need to engage the patients. And it is a question of your will. Thank you.
You can judge by that response from the audience how deeply grateful we all are for you sharing your deeply personal stories in such a powerful and memorable way. So we have 11 minutes for questions. We're going to convene to these nice, soft, comfortable chairs to our right. And if you can just gather your thoughts, if you have any comments or observations or previous experiences you want to relate, we'd like to hear them. I would ask you to keep your questions brief and focused. The Irish sometimes ask 5 questions in one, so don't use that technique this morning if you wouldn't mind. Okay, please. So we'd also welcome any questions from the AMEE Online live participants at home. So are there any questions from members of the audience? If you'd like to come to the nearest available microphone. Perhaps you could identify yourself. Yes, so microphone 1. Sir.
Good morning. I am Dr. Kinney from Florida, USA. I had seen this video many times. It's very touching, and I am blessed that I'm here to meet you in person. This is just a comment. I don't have questions. You taught me a lot. I have practiced medicine for 50 years, but your video made a big difference the way I teach my medical students. I use this video, and I have your permission, I hope, to continue to use this at orientation of my medical students, every group, with the hope that I will have played a very small role in producing physicians who will believe in this and not put their patients at risk, like your doctors and others put your family through. Thank you again.
Can I make a comment? Yeah. Thank you. I'd just like to thank you for that comment, and I do want to share that last night I called the producer of To Err is Human, Mike Eisenberg, and asked him how many screenings they have done at medical schools, and he shared that in this past year they've done 120 screenings at medical schools. So this is, he would like to see, the producer of this would also like to see this as part of curricula for medical students.
I think we'd make an ideal learning resource for first-year students at orientation. I think that's a very good point. Another question from microphone 1.
Hi, Dan Mayer, Albany, New York. Thank you again, both of you, for your very inspiring talks. And I also want to echo Dr. Kenny's comments. It's something that your videos have been used in my classes on diagnostic error and medical error. And the specific question I had is, what advice would you give a patient when seeing a physician on how to help that physician reduce a diagnostic error?
Well, I would say there's a variety of things that patients can do to help prevent diagnostic error. And one is to come prepared, knowing your history and physical. One is, I think that doctors need to be trained to invite the patient into the diagnostic process, that we're not passive recipients, that we need to be part of discovery of the diagnoses. I think patients need to be encouraged to track their symptoms. There's wonderful apps now to track symptoms. Patients need to be encouraged to access their own medical records and to see their test results and their statistics and their labs. So we need to encourage doctors to make those available to patients. We need to encourage patients to follow up on test results to make sure that test results are communicated to the right people at the right time. We need to make sure that doctors are comfortable talking about uncertainty, because actually through research we found that patients are okay with uncertainty. It's more the doctors feel uncomfortable talking about uncertainty. It's okay. And so I think those right there will help doctor and patient be a team together on getting the right diagnosis. And if the doctor can't come up with the right diagnosis, we really encourage patients to ask, what else could this be?
There's a lot of activity in microphone 1 this morning. We'll just move to microphone 3 and then return to 1 if you don't mind. Sir.
Mars from Vienna. I must say, I'm not a clinician, I'm a biochemist. And this story about a misdiagnosis of jaundice of the newborn is absolutely devastating, unbelievable to me, because this is not a mystery. I remember in the early 1970s, this was a standard part of every curriculum. And I really think this story should make us think of how we deliver medical education. If something basic like that, which is part of preclinical instruction, probably starting even earlier, how that can be missed. Okay, I'm totally puzzled and I'm totally devastated.
Thank you. Professor Martz, do you want to respond?
Yeah, I'll just say something about that. I mean, kernicterus is a completely preventable condition. It was the second leading cause of cerebral palsy in the developed world prior to the 1970s. And this is an example about the importance of education. We eradicated kernicterus in the United States in the 1970s, so it started to fall off the radar. So young doctors and young nurses and young clinicians did not see the devastating results of high levels of jaundice. So it, kind of like smallpox, fell off the radar, and it became possibly a couple sentences in a textbook. But in my son's case, we learned that the nurses nor the resident knew that jaundice could cause brain damage. That's unacceptable. So that's why patients, as educators, when we started doing grand rounds and we started doing CME, we were kind of reigniting these clinical skills that got lost. And this is something as educators we need to make sure that things like that do not fall off the radar.
And can I do a quick follow-up? We have a similar sort of issue with just lack of exposure in my disease. There are a lot of young practitioners who, because of good therapies now, have never seen that type of devastation. And we're seeing a little bit of more relaxation, not so much urgency to get people started on effective therapy. But the reality is the window of opportunity is very small, and joint damage starts immediately. And we can't relax and think everything's going to be okay. So it's a similar, we can't let things fall off the radar. People do still end up like that, and it's because we're not being aggressive and quick with therapy and diagnosis.
I think Professor Martz's comment underscores the importance of involving patients as educators at every stage in the learning continuum, including in where the students learn the biomedical sciences to apply context to the learning of anatomy and physiology. We're going to take a question from AMEE online live. Please, Olga.
Yes, thank you. So We have a question on Twitter, but I think it might be useful for all of us to know also how can we access the whole documentary? Because what we've seen was a trailer, and we would like to know also if it's possible to watch it.
The whole documentary? The whole documentary is, let me think where it is.
It's Amazon.
Amazon, yeah, you can find it online now. If you Google "To Err is Human," it's on Amazon and several online movie stations now. And I'm giving Gerard a whole copy of it, so you can come to him as well.
Very grateful for that, Sue. I think there was a lot of other questions out there. I think in the interest of time, unfortunately, we will have to bring this session to an end. Could I just ask people if they have further questions for our two speakers, if they have enough energy left after that powerful session, to perhaps approach them during the coffee break. But also they'll be available in the foyer later this afternoon for a Meet the Expert session where you could informally approach them then. And I would just like, on behalf of AMEE, to present a small token of our appreciation for your wonderful presentation. If you'll follow me to the podium, please. So a very special certificate of appreciation and a gift from AMEE. Suzanne?
Great. Thank you.
And Sue.
Thank you. Stay and enjoy it.
This is a very appreciative audience. You gave a standing ovation to our wonderful musicians on Sunday evening. I think it's very appropriate that you would stand and applaud our patient educators today. Thank you again, Sue and Suzanne.
Brilliant. Brilliant.